In this section, we'll be discussing on one of the most common acid-base disorder which is seen in patients who are critically ill. That is the metabolic alkalosis. Unlike patients who present with metabolic acidosis at the time of admission, this disorder is seen more frequently after admission. Under normal conditions, the kidneys are able to excrete an enormous amount of bicarbonate ions. The disorder metabolic alkalosis, it is caused either due to loss of H plus ion or gain of bicarbonate ions or inability of the kidneys to excrete the bicarbonate ions. When I see a case of metabolic alkalosis, I ask myself, why is the kidney abnormally retaining bicarbonate? You should know that the reason to this retention, it is the key to treatment of this disorder. So how do we find the etiology of this disorder? It's found that after taking history and proper physical examination, almost major causes is secondary to aggressive therapeutic intervention, which is used to treat shock, acidemia, volume overload, severe coagulopathic conditions, respiratory failure, bowel obstructions, and acute kidney injury. In spite of all this, if the cause is not obvious, the etiology it can be narrowed down by measuring the urine chlorine. So, if the urine chlorine level is less than 20 milliequivalents per liter, that is due to volume loss, the cause could be vomiting or nasogastric suction, diuretics, rebound hypokalemia, contraction, balanced salt solution, alkali administration, and with the reduced kidney function, citrate and balanced salt solution. Now, the causes due to urine chlorine more than 20 milliequivalents per liter. It can be further divided into normotension or hypotension and hypertension. The causes with hypertension causing metabolic alkalosis is hyperaldosteronism, renal artery stenosis, kidney failure with alkali intake. The disorders causing hypotension with metabolic alkalosis, it can be severe hypokalemia, Bartter syndrome, Gitelman syndrome, and diuretics. It's found that this disorder it is saline responsive, whereas this section it is saline resistant. So all these causes can be remembered as alkali. A for aldosterone increased levels like hyperaldosteronism, L for loop diuretics or thiazides, K for alkali ingestions like milk and acids, increased intake, A for anticoagulants, a citrate which is a storage component in blood transfusion, L for loss of fluids, vomiting and NG section, I for increased intake of bicarbonate which is done usually in correction of metabolic acidosis. What happens in nasogastric suction or vomiting? Normally from the gastric parietal cells there is secretion of the hydrogen ions which causes the release of bicarbonate ion from the duodenum. This bicarbonate ion then combines with the already released hydrogen ion which is present in the gastric chyme to form water and carbon dioxide. So the net gastric acid secretion is a neutral in nature. In nasogastric suction or vomiting, there is loss of protons and so there is an increase in blood bicarbonate. Now, when the ECF is normal, that is the extracellular fluid is normal, HCO3 will be rapidly excreted by the kidney. In conditions when the extracellular fluid volume is low or there is hypovolemia, renin-angiotensin-aldosterone system is activated. As a result, sodium and water is retained. Potassium as well as the proton ion is lost, and so HCO3 is retained. Because of resuscitation with IV fluids, patients are frequently volume overloaded. As a result, many start the patient on aggressive diuresis using loop or thiazide diuretics. As a result, there is a bicarbonate retention which raises the pH. Furthermore, metabolic alkalosis is further exacerbated by hypokalemia from urinary losses of potassium. Another condition which causes this disorder is the rebound, which means that in an overzealous attempt to correct pH in patients with organic acidosis, a large amount of base is administered and so the disorder is developed. In another, when if kidney function is abnormal or volume contraction is present, the excess bicarbonate is not excreted and so metabolic alkalosis ensures. The use of citrate as an anticoagulant in blood products, especially fresh frozen plasma and platelets, it is found that if there is a transfusion of more than 8 to 10 units of red blood cells, it can cause metabolic alkalosis as citrate is converted into bicarbonate. This component is also used in hemodialysis, and it is found that if the rate of citrate administration is excessive, the blood flow is limited or the membrane becomes clogged in the dialysis machine. As a result, citrate can accumulate, producing a metabolic alkalosis. Finally, in chronic hypercapnia patients, the kidney causes the hydrogen ion excretion and bicarb to be reabsorbed, and so metabolic alkalosis develops, and further it can bring the pH back towards the normal. How do we treat this disorder? First, identify the etiology and treat it. Secondly, it is found that morbidity associated with alkalemia may increase above a pH of 7.5. If hypokalemia is noted, it should be aggressively treated, and whenever volume depletion is found, it should be addressed and corrected. Stop diuretics when alkalosis is secondary to diuretics. In these patients, administration of acetozolamide will increase the bicarb excretion, improving the pH. And usage of this drug, it should be cautiously done as to prevent hypokalemia when using this medication. And if it is present, it should be corrected. And finally, in patients with kidney failure and severe alkalemia, hemodialysis can also be considered. Regarding treatment of severe potassium depletion, if potassium level is found to be less than 2, regardless of the cause, it has to be treated. Secondly, this allows for the correction of metabolic alkalosis itself. Third, if patient's alkalosis is acutely life-threatening, dilute HCl can be used under extreme circumstances in ICU setting to reduce the patient's bicarb promptly. In conditions like mineral corticoid excess, sodium chloride replacement is generally contraindicated because these patients are already volume expanded and hypertensive. Such patients require KCl's replacement in addition to specific therapy aimed at underlying disease. Secondly, in treatment of BAFTA syndrome, KCl supplements alone are not sufficient. In such cases, NSAIDs and potassium sparing diuretics can be given as an adjunct therapy, and so with treatment the serum potassium may stabilize to a level greater than 3 milliequivalents per liter. Finally, coming to the complication of this disorder, it can cause electrolyte imbalances like hypocalcemia and associated symptoms like paresthesia, tetany, muscle spasm and seizures. Second complication is due to decrease in respiratory drive. It makes the patient to be difficult to be extubated in those patients who are already ventilated. Third, electrolyte abnormalities includes hypokalemia and hypomagnesemia, and its associated ECG changes like supraventricular tachycardia, ventricular arrhythmias have been reported, as well as tetany and weakness. I hope this session was useful. Thank you and have a nice day.